All right, Dr. McDermott, I think we're going to get started if you're ready to go.
Yeah, that sounds great.
Okay.
I have a PowerPoint.
Perfect.
So I will.
I'm going to share your screen. There you go.
That work?
That works. I see it perfectly.
Great.
So without further ado, thank you so much, everybody, for joining us this morning. Epilepsy 102, why to go to an epilepsy center and what are your next steps? We are very, very lucky this morning to have Dr. McDermott join us and give this talk. She's associate professor in neurology at the University of Colorado Uncet's medical campus, where she completed her neurology residency and epilepsy fellowship. Dr. McDermott serves as the medical director of the Epilepsy Monitoring Unit at the University of Colorado Hospital. She has served on the Professional Advisory Board, PAB, for the Epilepsy Foundation of Colorado since 2013. Dr. McDermott was recently selected to the National PAB and serves on the National Advocacy Committee. Dr. McDermott's focus in clinical care includes surgical epilepsy and surgical evaluation for patients living with medication-resistant seizures. She's active in multidisciplinary specialty clinics, clinical trials, quality improvement, and clinical outcome research. Dr. McDermott believes in multidisciplinary approach to patient care with a strong focus on behavioral health and patient education. Her goals are to promote quality of life and incorporate aspects of integrative medicine. Thank you so much, Dr. McDermott, and I will let you take it over from here.
Well, thank you for having me. This is a pretty comprehensive talk in a short period of time, and I want to make this as it says, as interactive as possible. So we're going to have some pauses during this talk where we'll be able to specifically have some questions from the audience about some of the information that I'm presenting. To give you a brief outline for this talk, what I'm going to talk about specifically is what is epilepsy and how we distinguish epilepsy from having a seizure, and what defines medication-resistant epilepsy. And what is an epilepsy center? What is the impact of epilepsy, and how does that tie into why that may drive someone's decision to go to an epilepsy center? How do we define treatment goals, and how are treatment goals and treatment options different from one patient to another? And how this all ties in to advocacy. So an epileptic seizure is a symptom that is caused by abnormal and excessive electrical activity of nerve cells. So the nerve cells are located in the outer layer of the brain, that is the cortex or the gray matter. During this seizure, there's an imbalance in these electrical impulses, and this leads to excess excitation, which causes this outward manifestation that we call a seizure. A seizure can occur as a result of sudden changes within the brain that are due to triggers, or we can call these provocations. So these triggers can be things like alcohol or lack of alcohol, drugs, an acute injury, abnormal blood sugars, too high or too low, a disturbance of an electrolyte, and we call these provoked seizures. And often there is no long-term medical treatment necessary to treat a person who has a provoked seizure. It is often sufficient to remove the trigger. Now, how is that distinct from having epilepsy? So what is epilepsy? So the epilepsy is the fourth most common neurological disorder, and it affects people of all ages. Now, if a seizure is to occur repeatedly with no provocation, we would say that a person has a seizure disorder or epilepsy. Epilepsy then means having chronic or repeated unprovoked seizures. So the word epilepsy does not indicate anything about the type of seizure, the cause of somebody's seizure, how severe the seizures are. It is a spectrum condition. So this means that there are many types of seizures, and the control of somebody's seizures will vary. It is a very individualized condition. A word about an MRI and an EEG in epilepsy. So this is something that my patients ask me about all the time, that I went to the clinic and I had an outpatient EEG, which was normal. How can I have epilepsy? Or my MRI was normal. How can I have epilepsy? And it's important to recognize that a 20-minute EEG and an MRI are normal in a majority of patients who have had more than one seizure. This is because EEGs in many cases are abnormal only while the person is having a seizure. So what is the difference between epilepsy and then medication-resistant epilepsy? So medication resistance is suggested by the failure of 2 appropriately prescribed anti-seizure medications to control somebody's seizures. So to give you an idea, about 800,000 Americans experience seizures despite taking anti-seizure medications. And after trying 2 medications, the chance that a 3rd medication will control seizures is approximately 5%. Now there's some good news and then there's some not so good news. The good news is that about half of people will respond to the first medication used to treat seizures. Now this is the first medication, again, that's appropriately chosen at an appropriate dose, and it's not that the patient didn't tolerate it. But after that, the response to medication diminishes. So with the second medication, it's approximately 15%, and then there's diminishing results with additional medication. This is a study that was done and repeated by Kwan and Brody, and then done again in follow-up. So what about different types of epilepsies? And I know that there's speakers that will be talking about what is the difference between focal or partial onset seizures, which is a seizure that will begin in one part of the brain, which may spread to involve other parts of the brain. And within all forms of medication-resistant epilepsy, this composes about 2/3 of drug-resistant patients. Compared with generalized onset seizures, where the electrical activity is abnormal from the onset, that would compose about 1/3 of drug-resistant patients. So I want to stop right there and ask if there's any questions about seizures and epilepsy and then drug resistance.
Thank you, Dr. McDermott. I don't see anything in the chat, but feel free to use the chat if you have any questions, as we'd like to make sure we answer all your questions in a timely fashion.
Okay, I'll keep going.
Okay.
Okay, so when we talk about goals in treatment, the main goals are to enhance quality of life. And so it's important that you and your physician, whether it's your neurologist or epileptologist, look to establishing these ahead of time, and whether this be to treat and eliminate seizures, to minimize medication-related side effects. The impact of epilepsy is much more than having seizures. So thinking about how epilepsy may affect your quality of life may relate to medication-related side effects, but also what impact seizures have on relationships, on self-esteem, on mood, on limitations to work, education, finances, driving and transportation, worry about potentially the next seizure, and all the misperceptions of epilepsy. And the list goes on. And so it's very important to be able to establish a relationship with a provider where you can really prioritize how epilepsy affects you. So at an epilepsy center, it's important to understand that this is a specialized location where the facility is able to appropriately diagnose and provide treatment options for all patients with epilepsy and seizure disorders. So there is a team, a comprehensive team with specialists, including epileptologists, who are board specialized neurologists, specially trained in treating epilepsy and seizure disorders. Also, epilepsy neurosurgeons, neuropsychologists, radiologists specifically trained in neurology, epilepsy nurses in an epilepsy monitoring unit, psychiatrists with specific training in understanding epilepsy, EEG technologists, and even more. The National Association of Epilepsy Centers is a non-for-profit organization with approximately 230 specialized epilepsy centers in the United States. Now, the NAAC provides standards to promote guidelines where for accreditation of all of the programs for what we call specifically level 3 and level 4 centers, but these are centers where patients may be referred for specialized care or potentially even surgical care of difficult to treat seizures or even appropriate diagnosis of seizures. In Colorado, we currently have 6 epilepsy centers designated by the National Association. When talking about the levels of care at an epilepsy by the NAAC, I was actually surprised the first time I ever saw this, that a level 1 center is actually evaluation in the emergency room, or perhaps through a primary care physician. And I think many may agree that far too many of our patients seek care through the emergency room and potentially never make it to even level 2. Level 3 and level 4 centers provide specialized epilepsy care and again, seek accreditation by the National Association of Epilepsy Centers. So the National Association of Epilepsy Centers recommends referral to a comprehensive center if your seizures are controlled after either 3 months of care by a primary care provider or 12 months of care by a general neurologist. Quote, delayed or denial of a referral may be detrimental to the patient's health, safety, and quality of life. So what are level 3 and 4 centers? A level 3 center is able to provide more basic evaluation, medical, neuropsychological, and psychosocial services, and typically more straightforward epilepsy surgeries, VNS surgery, and then some more straightforward intracranial surgeries. Level 4 centers are the highest level designation and are able to offer complex neurodiagnostic evaluation and extensive treatment options. So to offer a complete interdisciplinary evaluation and offer a broad range of surgical options. So what are some of the advantages may you learn by going to an epilepsy center? So one is to get answers. The other is, that about 30% of patients that are sent to a comprehensive epilepsy center for uncontrolled seizures find that they were misdiagnosed. Others may be medication management. So in some cases, epilepsy diagnosis is correct, but maybe the medication regimen is not appropriate for that particular person. Other options include specialized clinics and epilepsy surgeries. In addition, the team is approach to is able to better help patients with other conditions such as mood, anxiety, and social needs. The specialized clinics include things like ketogenic diets, neurofeedback, pregnancy clinics, neurocutaneous disorders, and clinics for patients who have non-epileptic seizures. In addition, there are epileptologists and surgeons with expertise in different types of epilepsy surgeries and involvement in clinical trials. So when should you seek care? So you should seek care, as when we talked about, if you continue to have seizures after a trial of 2 medications. But despite these recommendations, 80% of patients remain at either a level 1 or level 2 center. It takes a person with medication-resistant epilepsy an average of 15 years to be referred to a comprehensive epilepsy center. Any questions right now?
Yes, we have a question, Dr. McDermott, and it's from Christopher. Is there a number of seizures you must have in a certain time frame or be on drugs for a certain time to be considered refractory? I have tried 5 drugs and none have worked, but I've only been having 1 to 3, I'm guessing, seizures per month.
So I'll speak broadly is that number one, it's important that when I gave the definition for medication resistance is that it's the failure of 2 appropriately chosen medications, meaning for your type of seizure, meaning if it's a generalized epilepsy or focal or partial onset seizure. So that's number one. So it's to establish the diagnosis. Number 2 is that intolerance, meaning like stopping a medication due to side effects early, would not count in that sort of a medication, so-called failure to respond. So if you were to start a medicine and take it for about a week, and have a side effect to that medication, we wouldn't consider that a medication non-response. So it would be 2 medications appropriately chosen and at an appropriate dose. So I would have to say that it would depend on if all of those criteria were met.
Thank you. And I hope that answers, Christopher, your question. I have another question if you just want to go ahead, Dr. McDermott, and answer it now. If a patient has known structural abnormality and seizure, increased likelihood of seizures, are they considered to have epilepsy?
Can you repeat that, please?
If a patient has known structural abnormality and seizures, increased likelihood of seizure, are they considered to have epilepsy?
So if a patient has seizures and a known structural abnormality, is that epilepsy?
Correct.
So as you know, my prior slide had stated, so epilepsy is a state of a tendency for one's brain to continue to have seizures when there is no provocation. So, so yes, that would be epilepsy, is a tendency toward seizures or a tendency to have recurrent seizures. So there may be many different reasons why a person may have seizures or epilepsy. It may be due to something structural. It may be due to something genetic. It may be due to an infection. So the underlying reason why a person may have seizures may vary, but the seizures, the tendency for them to recur is what ultimately defines whether or not a patient has epilepsy.
Thank you, Dr. McDermott. Do you want to continue? There's a couple more questions, but do you want to continue with your presentation? Do you want to go to the questions?
I'll continue because there's.
Okay, perfect. I'll keep monitoring it.
Okay.
Okay.
So I'm going to go into some of the various treatments options that are provided in a kind of whirlwind type fashion. But so at an epilepsy center, I alluded to the fact that we have dietary clinics often, and this actually applies to adults as well as pediatrics. And so typically dietary treatments for patients who have epilepsy have a significant carbohydrate restriction and generous fat intake. So when we talk about these as a group, we call them the ketogenic diets. There's the standard ketogenic diet, which is more often used in the pediatric populations, but most commonly in the adult population, we use the modified Atkins diet. That was the kind of trendy Atkins diet that then is now called modified, as it's not intended for weight loss. And then a low glycemic index diet. The dietary therapy comparison, so at the top you can see what a standard diet may look like, with about 50% carbohydrate, about 35% fat, and about 15% protein. And with the modified Atkins diet, you can see how the carbohydrate has become about 6% of the dietary intake compared with 50%. So, and then with the low glycemic index, carbohydrates are about 10%. And then with this ketogenic diet on the left, it's about 2%. If you look at the ketogenic diet, the fat is about 90% compared to about 65% on the modified Atkins diet and about 60% on the low glycemic index diet. So quite a bit different from the ketogenic diet to the modified Atkins diet, but with assistance of a dietitian and some coaching, patients do quite well. Another thing I thought I would touch on, especially since I am in Colorado, I thought I would bring up cannabis. And so this is one of my favorite questions in the office. So I thought I should touch on this. So patients say, well, does cannabis work to treat epilepsy? And we're actually pursuing a large survey on this to understand what patients think, because I was really interested to understand in our current context of, I guess I would call it decriminalization, what patients' perceptions are. But we know that there are mixed results. So we know that the THC, or one of the compounds within cannabis, has either anti or pro-convulsant, pro-seizure effects, depending on the dose and the epilepsy model that is studied. And there are many cannabidiols that have variable effects. It should not be understated that with the types of ways that it can be consumed, meaning inhaled and vaporized and so forth, that there are other potentially negative health consequences. And there's even been a question of, can there be withdrawal seizures related to this? Now, of course, it cannot be prescribed, and I've not, it's rarely prescribed, I would say, by an epileptologist, but except for in states, again, with a medical cannabis. This is to be distinguished from Epidiolex. So not to say that, to make sure that there's a understanding that Epidiolex actually is FDA approved. And this is a CBD compound that is approved for the treatment of DRAVET syndrome, Gastaut syndrome, and tuberous sclerosis related epilepsy. It's dosed per weight, and there are drug interactions that patients need to be aware of. In an epilepsy monitoring unit, and I'm going to be moving towards more surgical discussions, we have an elective admission for a video EEG for the distinct purpose of characterizing, meaning what is this movement that is happening. So is this a seizure or is this potentially not a seizure? Localizing, where is the seizure coming from? Or what type of epilepsy do I have? And then surgical evaluation, meaning in characterizing and localizing for the purpose of potentially intervening on a patient who has medication-resistant epilepsy. Sometimes patients are admitted for medication adjustment and some other reasons as well. So when we have a patient who has medication-resistant epilepsy, they may become a candidate for devices. One device that is the vagus nerve stimulator, or the VNS. This, you can see this kind of blow-up depiction of this device. The device has a battery that lives in the chest wall, and then wraps around the vagus nerve that is here yellow in the neck. And so there's a coil that wraps around this nerve and delivers a pulse stimulation about approximately every 5 minutes that lasts about 30 seconds. This is done typically in an outpatient OR setting, and the patient will come back a couple of weeks later and have the device programmed over approximately 6 visits. Maybe 5% estimated may become seizure-free, but for most patients, it will help reduce the frequency and severity of seizures. It can also be used with a magnet, and there's other types of cycles on the nerve stimulator that may detect changes in heart rate, for example, to help interrupt and stop seizures. There's a question of, does a vagus nerve stimulator, is it more effective in certain types of seizures more than others? A meta-analysis or pooled studies, including randomized and non-randomized studies, or non-blinded, I'm sorry, showed that perhaps there's a slight increased benefit in generalized onset seizures compared to partial or focal onset seizures. So 58% decreased seizure frequency in generalized compared to 43% reduction in focal or partial. So moving on to phase 2 monitoring. So I spoke briefly about phase 1 monitoring, or in the epilepsy monitoring unit. And so sometimes we have to move on to more invasive monitoring, and where I am, we call it phase 2. And it's also called intracranial monitoring. And so this may be recommended if the seizure onset is not very clear from the scalp monitoring, or sometimes when the MRI does not show a lesion or an abnormality that we are confident is causing the seizures. So this intracranial monitoring refers to monitoring done with electrodes that are placed within the brain with depth electrodes, or on the surface of the brain with grid and strip electrodes. These are placed by a surgeon in the operating room and under general anesthesia. So here's a depiction of what this might look like. On the left side, you can see what depth electrodes may look like. And these little dots are the electrodes, and they're placed strategically in an area where the epilepsy team has planned in advance to place where they think that the seizures may be coming from. On the right side, you see much more extensive kind of surface array, which is a grid. And the green is a big grid on the frontal lobe area. The pink one is on the temporal lobe, and then you have a little strip in the back. The patient actually then goes back to the epilepsy monitoring unit and undergoes seizure monitoring just as they would have in the so-called phase 1 portion. And seizures are then patient has seizures under video EEG, and when enough information is obtained, the electrodes are removed several days later after the seizures have been localized. So we make these, we do this so that we can say, well, do we need this information to guide something like a placement of a responsive neurostimulator, or do we need to do this in order to guide something like an ablation or a resection? So an Rns device or a responsive neurostimulator is a neuromodulation or neurostimulation device where the electrodes are placed directly on or in the brain and remain there in order to stimulate areas that have been found to trigger seizures. So the stimulation is aimed at interrupting seizures and has been shown to reduce seizure frequency. So this is what we call a closed loop responsive stimulation system, where it is constantly monitoring activity, it's sensing it, it's detecting a pattern that it's programmed to detect, and then automatically stimulating it. And it's recording it over months and years, and an epileptologist is able to program the device in response to trends that are seen over time. So the electrodes have to be placed with a good understanding of where the seizure starts. So even though not all patients will require intracranial monitoring, many will, the patient must also be able to download data from the device that is placed in the skull onto a laptop typically once daily, and then upload this data to share with their epileptologist approximately weekly. And then the patients will have follow-up appointments about every 2 to 3 months, at least at the beginning of the course of their treatment. So from a long-term efficacy or how well does this work kind of perspective, at year 8, there was a 73% median seizure reduction, and 66% achieved 50%, greater than 50% seizure reduction, and 30% achieved greater than 90%. About 29% of patients had about one period of greater than 1 month, 6 months without seizures. This is an example of one of my patients, and you can see this is what an evaluation might look like. So this is a depiction of this patient's EEG and shows the beginning of a seizure. This is where we were able to demonstrate that this is where the patient's seizures began. In fact, this patient has tuberous sclerosis and was the first patient implanted with an RNS and had tuberous sclerosis complex. So the patient had the RNS implanted, which was guided by this invasive monitoring. And after about 4 years, the patient reports that she has less than a seizure a month compared to about 3 a week. And she and her husband both report that her seizures, when she does have them, are shorter and milder and have a shorter postictal period. You can see that from the device itself, you're able to see that her trends have gone down over time. I want to speak quickly about laser surgery, which is a newer minimally invasive surgical technique, which can be used in patients who have small lesions that cause seizures. So laser surgery is used under a guidance system we call the stereotactic. And through a small hole in the skull, a laser tip is placed in the middle of the target area. And the energy transferred, which is thermal or heat energy, is moderated by the MRI to control the laser. So this is destruction of this lesion by heat, which is called thermal ablation. This is much less invasive than what we were able to do in the past with large open craniotomies, for example, and the patient is able to go home much earlier because there is only a small surgical wound. When recovery time is expected to be faster than when there is an open resection. And this is an example of a patient who is having this catheter tip placed in the hippocampus to have a hippocampal ablation. So you can see that this tip of this laser is heating up and would then be basically ablating this tissue here. So as a word to advocacy, be your own advocate. So if you are suffering from seizures despite medication, but a prior surgery, or having a vagus nerve stimulator, I recommend that you find your way to a comprehensive epilepsy center for a comprehensive evaluation. One way is to go to the National Association of Epilepsy Centers website. So it's naecepilepsy.org. I've also put our monitoring unit's website at the bottom as well. And mentioning next year, maybe we would all be together live. That would be wonderful. But next year, we're slated for November 8th, 9th, and 10th. So thank you to everyone, and I'm happy to take further questions.
Thank you, Dr. McDermott. Lots of information. I'm sure there'll be lots of questions, and thank you for sharing your contact information as well. There was a question from Cindy as it pertains to diet. Are these carbs, are these carbs, quote unquote, starchy, or including fruit and vegetables?
So the actual carb does not, you know, you're allowed a certain number of grams of carbohydrates per day, depending on your body weight and so forth. So, you know, typically it's no more than 30 grams a day, and often it's less than that. And so you can use it all up pretty quickly. So you're basically counting carbohydrates every day. So obviously starchier foods, or you will consume your carbohydrates much quicker than eating, for example, a raw banana has much fewer carbs than a ripe banana, which is interesting. So so yes, it's a matter of counting carbs and maintaining ketosis, which is checked by checking your urine with what they call a keto stick, which is a strip that measures how many ketones are in your urine. But I would say that it's very important, if possible, to find a neurologist and epileptologist that work with a dietitian that's able to make sure that you have all the appropriate nutrients in your diet as well, because you know, these are monitored typically at the beginning of the diet and then on an intermittent basis.
Thank you, Dr. McDermott. The next question comes, and it just popped away, from Karen. Actually, she has two questions. Just to clarify, if phase 1 is unclear as to focal point or just generally unclear as to what is going on, is phase 1 repeated, or do we continue on to phase 2? Also, does phase 2 testing have to be done in the majority of cases in order to be considered received an RNS?
So a phase 1 may need to be repeated if it is what we call non-diagnostic. So if the information that there may be multiple reasons for this. So a patient may come into the monitoring unit and not have a seizure. And this is very frustrating for some patients because they have seizures all the time at home. And then all of a sudden, you know, it's time to come to the epilepsy monitoring unit and nothing happened. This is not uncommon. The other scenario may be that, that a patient had, something, but it wasn't their typical seizure. So there are different types of scenarios where a phase 1 may need to be repeated. I cannot see a situation where a patient would bypass a phase 1 and go on to a phase 2 without the information that would be necessary. So that is determined by the team, again, an interdisciplinary team of epileptologists and surgeons. And where I am, we meet weekly and discuss potential surgical candidates. And when I talk to my patients, I say, well, we need to make sure that not only is the surgery options that we present to you are appropriate, but that they're, we look at the safe, the risk versus benefit to you. So when we also talk about RNS and does a patient need a phase 2 for an RNS, different centers, I believe, approach this differently. I would say that not always does a patient need a phase 2, I would say, but if there's any doubt as to whether, as to where the seizures are coming from, a phase 2 may be recommended.
Thank you, Dr. McDermott. Karen, we hope that that answers your question. We have another question from Christopher. I'm 34 and have focal complex seizures. So far, I've been on close to 6 drugs over 10 years. Some have worked for a year and then stopped working. Is this common for all drugs?
So again, without knowing any of the details, I would say that, many patients go through medication trials, and I call it the medication merry-go-round. But again, it's important to make sure that the doses, the medication is appropriately chosen, the doses are appropriate, and and I would recommend, if you haven't, that you do seek an epileptologist to guide the next steps in your treatment.
Thank you, Dr. McDermott. And Christopher thanks you. So I think those were all our questions. We did have a comment from Dr. Robert Fisher. Subject of the next talk is can have epilepsy after one unprovoked seizure if the chance of having another is over 60%. And he is the chair of the definitions committee. So he added his little comment. Somebody was watching you, Dr. McDermott. He's joined us. Thank you, Dr. Fisher.
Thank you.
We got another follow-up question from Karen. Yes, thank you. At Anschutz, is phase 2 testing done often?
So I'm not sure. So we have often, meaning do we do it frequently? Yes, I would say we have about 1 patient, 1 to 2 patients per week that undergo phase 2 monitoring. So in terms of volume, I would say that the volume is pretty high, but it's all relative. Some epilepsy centers are, bigger than others, but I would say our volume is relatively high.
Thank you.
Thank you.
She said, sorry, I meant, is it available at Anschutz easily, or do they refer to another center? Thanks.
I see. No, we do all of our, all of the phase 2 is done at Anschutz Medical Campus.
And that's all I have in the chat. If anybody has any questions, we still have a couple of minutes left before the next talk with Dr. Fisher, but Dr. McDermott would definitely entertain those questions. If you have some, type them into the chat and we can get an answer for you. Otherwise, we thank you so much for joining us this morning. And thank you, Dr. McDermott, for taking the time to volunteer and give this wonderful presentation to our guests this morning. So thank you.
Thank you.
And in some parts of the country, it's the afternoon. I'm on the West Coast, so I always refer to our time here. Thank you very much.
Thank you. Have a wonderful day.
Thank you, Dr. McDermott.
Okay, bye-bye.
Thank you, everybody.